Okay, let's unpack this. Imagine you're experiencing persistent, genuinely distressing physical symptoms, maybe chronic pain, digestive issues that just won't shift, crippling fatigue.
Right.
You feel unwell. It's definitely affecting your life. But test after test comes back normal.
Hmm.
Your doctor can't find a clear medical explanation. How incredibly frustrating and maybe even isolating must that feel?
Absolutely, for the person experiencing it, obviously, but it's challenging for clinicians too.
Yeah, that disconnect, between someone's real suffering and the limits of what standard medical tests can show. That's really the heart of these kinds of conditions.
Yes, it really is.
Exactly. And that experience brings us straight into today's deep dive. We're going to tackle somatic symptom disorder.
Which used to often be called somatization disorder, right?
Precisely. We've got a stack of pretty detailed revision notes and overviews here, perfect for anyone needing a really high-yield breakdown. Maybe you're studying, maybe you just want to understand it better.
Yeah, so our mission today is basically to pull out the absolute must-know nuggets from these sources. Think of it like streamlining your revision notes. What do you really need to grasp about SSD's definition, the causes, how it looks, uh, diagnosis, management? Let's make sure these key points stick.
Okay, let's do it. So, starting with the basics from these notes, how do they define somatic symptom disorder at its core?
Well, the fundamental thing, according to these sources, is having multiple physical symptoms. But crucially, these symptoms don't have a clear, identifiable medical cause found through investigation.
But it's more than just unexplained symptoms, isn't it?
Oh, definitely. The key is that these symptoms are chronic, they persist, and they're severe enough to cause real distress or significantly mess up your daily functioning.
And the focus of that distress is quite specific.
Yes, that's a good point. Usually the main worry isn't like, oh no, I have a terrible disease, although that can happen in related conditions. In SSD itself, the distress is really focused on the physical symptoms, the pain, the nausea, whatever it is, and the thoughts, feelings, behaviors around those symptoms are sort of disproportionate.
Right, and this whole concept, it's actually been labeled differently over time. The notes highlight quite a big evolution in the diagnostic manuals.
They really do. If you look back at ICD-10, it used the term somatization. That required multiple recurrent changing physical symptoms for at least 2 years before you even get referred.
2 years.
Yeah.
Oh,
Then ICD-11, the newer one, uses bodily distress disorder. That focuses more on the physical symptoms, plus the person frequently seeking medical help, even when tests are negative.
But the really big shift, the one that seems most important clinically, is with the DSM-5.
This is where it gets, well, really interesting and definitely a high-yield point if you're revising. DSM-5 brought in somatic symptom disorder, or SSD, as this broader term, replacing several older diagnoses like somatization disorder.
Okay.
And the critical change, the absolute key takeaway from DSM-5, is that the symptoms don't have to be medically unexplained anymore.
Really? How does that work?
So someone could have a diagnosed medical condition, like, say, heart disease. But if their thoughts, feelings, or behaviors about their symptoms are excessive, disproportionate, and cause significant distress or life disruption, they could also meet the criteria for SSD.
Ah, I see.
And that old rule about needing a specific number of symptoms from different body systems, that's gone too in DSM-5.
Wow, okay, that is a massive change in thinking. It's less about whether the symptom has a known physical cause and more about the person's reaction and how much it impacts their life.
Exactly. It's about the response to the symptom.
Okay, so we've got the what and how that definition has evolved. What about the why? The etiology, the causes. Seems pretty complex based on this material.
Oh, it is. The sources are clear. There's no single smoking gun. It's a really complex mix of biological, psychological, and sociocultural factors all playing together.
Like what sort of things?
We're talking potential genetic links. The notes mention maybe neuroendocrine genes, but it's not fully pinned down.
Right.
Early life stuff like trauma or significant illness. Maybe even some differences in how the brain processes information. Neurobiological abnormalities, perhaps?
It seems like some people might just be more tuned into their bodies.
Physically. Precisely. That's mentioned a heightened perception of normal bodily sensations. It's like the volume knob is turned up on internal signals most people would just filter out.
Right.
And this rarely happens in isolation.
You mean comorbidities, other conditions alongside it?
Yes, very common. You often find SSD along with things like irritable bowel syndrome, chronic pain, PTSD, anxiety, depression, even antisocial personality disorder in some cases, interestingly.
And the psychological angle is pretty big, too.
Definitely. Things like catastrophizing, jumping to the worst possible conclusion from a minor symptom and high levels of health anxiety are major factors.
Mhm.
The sources also sort of float the idea that maybe unconsciously the symptoms might serve a purpose for some people, like seeking attention or maybe getting out of difficult situations or expectations.
And the trauma link comes up again here.
It does. A history of abuse, sexual or physical, is definitely associated with increased risk. It seems like these negative psychological factors and past experiences can make it more likely that even minor physical feelings escalate in the person's mind and become really severe, disabling symptoms.
Okay, so for revision on causes, etiology, we're
Yeah.
thinking biopsychosocial, genetics, early life, brain differences perhaps for bio,
Right.
catastrophizing, health anxiety, trauma, maybe unconscious factors for psycho,
Yep.
and then sociocultural, like how illness is viewed in their environment. Okay. Building on that, what makes someone more likely to develop SSD? The risk factors.
The notes pull out some key ones. Think about vulnerability. A family history of SSD points to maybe genetic or shared environmental stuff.
Makes sense.
History of childhood abuse or trauma, as we said, is a big one. Certain personality traits, especially neuroticism, that tendency towards worry, negative emotions, being emotionally unstable, that increases susceptibility.
Okay.
And just not having good ways to cope with psychological distress. If you can't manage stress well emotionally, it might come out physically instead.
Right. So family history, trauma history, personality style, and coping skills. Got it. Now let's try to get underneath it. The pathophysiology. What's actually happening physically? What do the sources say?
Well, this section is pretty direct, actually. The sources state quite clearly that the underlying pathophysiology of SSD is just not well understood.
Huh. So despite all the research, we don't have a clear biological pathway yet.
Not really, no. The main ideas, the hypotheses, involve things like maybe alterations in how the brain processes pain signals, that heightened sensitivity to normal bodily sensations we mentioned earlier, and maybe maladaptive cognitive and emotional responses to stress somehow affecting physical processes.
Right.
It's also noted, logically, that if someone also has anxiety or depression, that can definitely influence how their physical symptoms show up and how long they stick around.
That makes sense. Given that the physical symptoms can look like so many other things, how do doctors actually figure this out? This must be where differential diagnoses are crucial.
Absolutely critical. Job number one for the clinician is to rule out other medical conditions that could actually be causing the physical symptoms. Requires a really thorough history, a physical exam, and, targeted tests, labs, imaging, whatever's appropriate.
What kinds of things need ruling out?
Well, obviously, actual organic medical diseases,
Yeah.
but also other related disorders like illness anxiety disorder, where the main worry is about having a serious illness rather than the symptoms themselves being the main focus of distress. And then you've got factitious disorder. That's where someone deliberately makes up or fakes symptoms because they want to be in the sick role.
Right. Munchausen's is a term people might know.
Exactly. And malingering, which is faking symptoms for some kind of external gain like money or avoiding work. The key difference with SSD is intent. In SSD, the suffering is real, it's genuine distress, it's not intentionally faked for gain or just to be seen as sick.
Okay, so a big medical workup to exclude other causes and a psychiatric assessment to look at the whole picture and rule out those other conditions or deliberate faking. Got it. How common is this? Who gets SSD? Let's touch on the epidemiology.
Yeah, the numbers vary a bit. Probably depends on how it's diagnosed and who they're studying. The sources mention UK estimates anywhere from 0.2% up to 2% of the population. That's quite a range.
It is.
A general population figure of 5-7% is also cited sometimes.
In demographics. More common in anyone.
It can affect anyone, really, all ages, both genders, but it's generally thought to be more common in women, and it often starts before age 30. The notes also flag potential geographic or cultural differences. Like one German study found it was higher, about 7.7% in primary care settings, which makes sense. That's where people first go with physical issues.
Yeah.
And another finding mentioned was it being more common in people over 60 in China, so how it presents might vary with culture or age.
Interesting. Okay, now let's get really specific.
Yeah.
What does SSD actually look like day to day? What are the clinical features someone might present with?
The absolute hallmark, as we've said, is multiple physical symptoms across different organ systems. And these symptoms either lack a clear medical explanation or the person's reaction to them is just way out of proportion. The key is the breadth. It's not usually just one thing.
Can we run through some examples from the notes, maybe
Yeah.
group them by body system to make it stick for revision?
Good plan. Think system by system. So cardiac, you might get shortness of breath, feeling your heart race, palpitations, chest pain. GI, gastrointestinal, this is super common. Vomiting, belly pain, trouble swallowing, feeling sick, bloating, diarrhea, lots of gut stuff. Musculoskeletal, pain is big here. Pain in the limbs, back pain, joint pain, neurological, things like headaches, dizziness, even memory loss reported sometimes, vision changes, maybe weakness or paralysis that can't be explained neurologically,
Wow.
and urogenital, painful urination, low sex drive, painful sex, impotence in men, and for women, issues with periods painful, irregular, or really heavy bleeding.
That's a massive, varied list. How on earth do you remember all that for an exam?
It's less about memorizing every single symptom and more about recognizing the pattern. Multiple symptoms across many different body systems, often shifting or changing over time. Like symptoms are sort of jumping around.
Okay, the pattern.
And remember that key DSM-5 point, the focus on the disproportionate thoughts, feelings, or behaviors about the symptoms. Is the person spending huge amounts of time and energy focused on them? Are they constantly anxious about minor sensations? That's a really important diagnostic clue now.
And the impact on their life is pretty major.
Oh, absolutely. These aren't just trivial aches and pains. The symptoms are severe enough to really interfere with daily life, work, relationships. Stress often makes them worse too, which can create a nasty cycle. And often you'll find if you dig into the history, there's a lifelong pattern of feeling sickly or having various physical complaints going way back.
Okay, so we know what it looks like. How is the diagnosis actually made? We talked about ruling things out, but is there a positive way to diagnose it?
Yes, exactly. While it often feels like a diagnosis of exclusion because you've ruled out so much else, the sources do stress that you can make a positive diagnosis. It's based on recognizing a typical cluster of features, but only after you've done a thorough medical workup to rule out other causes.
Okay, what are those typical features then? This sounds like key revision stuff.
Definitely high yield you're looking
Yeah.
for. 1, multiple symptoms across different organ systems that pattern again. 2, symptoms that are often vague, subjective. They feel worse to the patient than objective tests or exams might suggest. 3, a chronic course. It's been going on a long time. 4, often the presence of another psychiatric disorder like anxiety or depression. Very common.
Oh.
5, evidence of extensive prior medical testing. They've likely seen lots of doctors and had lots of tests. 6, and sometimes a tendency to reject previous doctors' conclusions when no physical cause was found.
Okay, that's a pretty clear checklist. Multiple, vague, chronic comorbidity common, lots of tests done, maybe a rejection of previous findings.
Yeah.
And there was that interesting point about the doctor's own feelings.
Yeah, the notes mention this. It's quite intriguing. If a clinician finds themselves feeling really frustrated or overwhelmed or like they're just banging their head against a wall despite all the tests, that emotional reaction can actually be a bit of a flag. It might prompt them to consider somatization as a possibility.
That is fascinating, sort of diagnostic clue from your own reaction. Okay, so the diagnosis is made. What then? How do you actually help someone with SSD? What does the management look like?
Right, management needs to be multidisciplinary, usually. A mix of approaches. And absolutely central is building a good, trusting relationship between the patient and their main healthcare provider. Psychotherapy is really key.
What kinds of therapy work best?
CBT, cognitive behavioral therapy, is mentioned a lot. It helps patients spot and challenge those unhelpful thoughts about their symptoms, learn better coping strategies, and maybe gradually become more active even with the symptoms.
Okay.
Psychodynamic therapy also gets a mention for exploring potential unconscious roots. There's also talk of short-term intervention therapy, maybe 8 to 16 sessions, focused specifically on improving function and reducing distress. And mindfulness therapy is noted as being feasible, acceptable, sometimes used alongside meds.
Speaking of meds, what about pharmacotherapy? Do drugs help?
SSRIs, the antidepressants, are mentioned. But the evidence specifically for treating the physical symptoms of SSD itself, the sources say it's pretty low-quality evidence, actually. However, SSRIs are often very useful because anxiety and depression are so commonly comorbid, so they treat those underlying or coexisting mood issues. If you do use them, the advice is start low, go slow with the dose. Patients with SSD can sometimes be quite sensitive to side effects.
Right.
Other antidepressants might also be used for those associated psychiatric conditions.
So medication is more for the associated anxiety and depression, not a direct fix for the physical symptoms themselves.
That seems to be the general idea from these notes, yes. But maybe the single most important part of management highlighted is actually communication and empowering the patient.
Yeah. Tell me more about that. That sounds crucial. How do you have that conversation?
Absolutely. High yield for anyone in practice. Doctors need to explain the diagnosis, explain the condition, but do it really empathetically. It's vital to involve the patient in understanding their symptoms from this different angle. Explaining it in a way that validates their suffering, acknowledges their pain is real, while gently shifting the focus away from this endless search for a hidden disease towards managing the symptoms and improving their life. That's empowering. It's shown to improve well-being.
Yeah.
That first conversation about SSD is apparently critical. You have to explain it without making them feel like you're saying it's all in their head or that they're making it up. The symptoms are real and distressing to them, whatever the underlying mechanism.
So it's about acknowledging the reality of their experience, but introducing this idea of how stress, thoughts, feelings can genuinely manifest physically.
Exactly that. And helping them develop better coping strategies is central. The notes mention things like using open-ended questions or techniques like BATHE, that's an acronym, background, effect, trouble handling, empathy. It's a way for clinicians to gently explore the psychosocial stressors in someone's life, which often tie into symptom flare-ups. Having one consistent, supportive main doctor or healthcare provider is also really helpful, rather than bouncing around specialists. Regular, maybe brief check-ins to see how symptoms are, review coping strategies that builds trust.
What about general health advice? Lifestyle stuff?
Yeah, encouraging physical exercise is important, not just for fitness, but it can help mood and self-esteem too. Stress management techniques, obviously key. And here's a really crucial point for prevention.
Go on.
People with SSD can still get actual physical diseases later on. Just because they have SSD doesn't mean every new symptom is part of it. So they still need regular health screenings, just like anyone else, for their age and risk factors. You can't just dismiss everything.
That's a really vital point for ongoing care. Okay, so what's the general outlook for someone with SSD? What does the prognosis look like?
It varies quite a bit, honestly. It depends on the person, how severe the symptoms are, and critically, whether they get the right kind of help. The good news is, with appropriate interventions, people can see significant improvement in their symptoms and how well they function day to day.
That's encouraging.
But the notes also say, it's often a chronic condition, and having other psychiatric issues alongside it can make it a long-term challenge. Ongoing management might well be needed.
And what about complications? If it's not managed well, what can go wrong?
The complications can be pretty significant, unfortunately. Obviously, a major impact on quality of life, difficulty functioning at work, socially.
Yeah.
There's a big burden on healthcare, frequent visits, hospital stays, endless tests, which racks up costs. High risk of developing or worsening anxiety and depression. That frustration and misunderstanding between patients and doctors we talked about, that can really damage the relationship and actually make the symptoms worse, perpetuate them.
It sounds like a real negative cycle.
It absolutely can be. Symptoms get really entrenched. There are even risks from all the investigations, complications from invasive tests, radiation exposure, and sadly, there's a risk of becoming dependent on substances, alcohol, painkillers, sedatives, just trying to cope with the chronic distress and pain.
Wow. That really covers a huge amount of ground from those notes. Definition, evolution, causes, features, diagnosis, management, prognosis, complications. It really paints a picture of a very challenging condition, but one that's so important to understand properly.
It is complex, no doubt, affects patients profoundly, and definitely requires a really thoughtful, empathetic approach from clinicians. Getting your head around these key points from the revision material is pretty essential for spotting it and managing it appropriately.
So, thinking about everything we've discussed, the patient's experience, the difficulties in diagnoses, that need for really empathetic communication, what does this all mean? How might a deeper understanding of somatic symptom disorder not just help with diagnosis and management, but maybe fundamentally shift that dynamic between patient and doctor when physical symptoms just don't fit neatly into a standard disease box? That's maybe something for you to mull over.
Yeah, definitely food for thought. And look, if you are working through complex topics like this one and you need some high-yield questions to really test your knowledge for revision,
you should absolutely head over to PassThemMSRA.com. They've got questions specifically designed to help you nail this stuff effectively for exams like the MSRA.
And for more free resources, things to support your learning journey more broadly, do check out freemsra.com.
Okay, that wraps up this deep dive on somatic symptom disorder. Thanks so much for joining us.
Thank you.